our agency has a whole host of services that it can offer, but today I'm mainly going to talk to you about our low vision clinic. So I always like to open with the agency because, again, the agency does encompass much more than the low vision clinic that we're going to talk about specifically today. So that is our main focus, and we will get into some of the other services, but I just want that understanding that the low vision clinic is one piece of what VIA is here to offer you. I also will get into some tips and tricks, and I do that because, again, if I were sitting there watching this presentation, I would want to walk away with something that I could actually implement. So hopefully I can bring that to you today as well, where you're able to implement, even if it's something minor, hopefully a little bit of something that could be relatable to your personal needs. This slide always looks scarier than it is. And there is no quiz at the end. The only reason that I bring this up, and I am aware of the irony of the small print of the labels of the parts of the eye. However, the whole reason I bring this slide up is not to go through the eyeball, because let's be honest, I don't really think that we want to learn the functions and all the muscles and the nerves. But I bring it up just to drive the point home. I think in our day-to-day life, it's very easy to forget how complex it is, right? I think we talk in terms of vision and seeing, and it's so simplistic in a conversation. And I like to bring this up to just say, my gosh, look at all the things that are involved with this, from, there's physical things like the muscles, all the way to nerves that are transmitting information, all the way from the fluid. And so it just gives that appreciation, because a lot of times it comes down to something so simple as I can't see well. And there's a lot of confusion about where to go to and for what, which is actually our next slide. But again, this slide is just to merely serve as a reminder to us when we are discussing vision and things of that nature, just how complex we're really dealing with, because I think it would be very easy to forget that there's a variety of people, providers, and medical intervention involved with the eye, because it's just one piece of our body, and yet look at that complexity. So again, not to overwhelm as much as to show that appreciation. And when we get into further discussions in this presentation, and I say something like macular degeneration, then you would see, you'll be thinking, and hopefully in the slide saying, oh yeah, that's part of the eye. Or we talk about, these are big words, but don't let them scare you, retinitis pigmentosa. And if you know anything about medical terminology, you go, oh, the word retina's in there. So again, that's when we're going to talk about these things. And the other piece to the slide is diabetic retinopathy is something we commonly see here. So people with diabetes will come to us. And I think when we look at this and we see all of the blood flow and those vessels that are in the eye, it's a good reminder of just the impact that diabetes may have on our vision, because there is so much blood supply that goes to that eye. So again, very, not a pop quiz, just showing for the appreciation of all of the things and functions that are really involved with vision. So to that point, we just talked about the health of the eye. And when we're talking about the health of the eye, we commonly will refer to an ophthalmologist. And here's where it can get a little confusing, because unfortunately, all of these words are extremely similar. However, when we talk about things like, people always call us and say, am I going to get the drops? Nope, you are not going to get the drops with us. That is where we go to, and we refer to an ophthalmologist. So that's the middle term we have there, ophthalmologist, and they're dealing, the simplest term is the health of the eye. So if you do need the drops, or if you suffered something like pink eye, you needed a retinal surgery, those are things you're going to go to an ophthalmologist for. And again, I have empathy for the confusion, because I've been in healthcare my whole life, and it took a long time for me to get these terms straight. And if anything, just remembering that there's many, many professionals on a vision team, so to speak, will be helpful. Please don't get overwhelmed by remembering what each of these does. Here at VIA, we have put somebody in the position of what we call triage, where they have the ability to sit with you and talk through. So should you call, they can work through that. And we put someone in that position because we do understand that this is a little bit of a complex thing. When again, we say just one thing, vision and eyes, it sounds like it's going to be simple, but there is a complexity, and we appreciate that. So therefore, as we get calls that are, people are confused and don't know where to start, we have somebody to work you through that. But again, the most basic thing we ask people to start with before they come to us, and this is a very common thing, not always, but a lot, we do ask people to check in with an ophthalmologist because they are going to look at the health of your eye and they will be able to look at those, what I call baseline needs, right? So that's where I would start. And that's where most people who come in have started there already. What happens typically is after the ophthalmologist has, I'll say, maximized what they can do or hit the end of what they can do, because they're only medical, we are another step beyond that. And what I like to call us is that functional next step. So the relatability factor of this becomes, I think when we all visit a doctor's office, right, whether that's your primary or a specialist, we're very much, unfortunately, all accustomed to usually waiting a long time, and you're only with that provider, 10, 15 minutes, and that's generous sometimes. What I like about what we do here in our low vision clinic is that you're going to get about 45 minutes to an hour of FaceTime with Dr. Simmons. And Dr. Simmons is our low vision optometrist. So he differs from an ophthalmologist in the sense that the easiest way to distinguish is he understands and knows vision, but we're going to talk with you at an appointment about the functionality behind that. So as I said in the beginning, one of the common calls we get is I can't read, or I'm having trouble reading, or I just had a call the other day. Somebody called and said, I can't see where the zipper is in my wallet because I had asked for their insurance card. Those are really good examples of where, I've seen my ophthalmologist, I've done the basic medical things, I'm stuck now and I need help functionally. So I just explain that because it is very confusing and I don't want to waste people's time or patience for that matter, because when you are struggling with vision, we very much can appreciate that the road is a little tough for you, and therefore we want to make that easier. So this is all just background knowledge to hopefully help ease whatever, if there's an anxiety about it. There's a lot of people, believe it or not, who are fearful of coming to visit us. And I think some of that fear is driven by you simply just don't know, because this can be overwhelming. So hopefully having this discussion demystifies some of that and makes it a little more comfortable. And lastly, the optician is the person who makes the eyeglasses. So if anything, who knew that and these are only 3 of the players in the game, who knew this many people were involved for vision, right? So we're talking about vision today, but specifically we're going to talk about what we call low vision. And the reason we talk about low vision is what I had said before, that functional word is after we've talked about medical with your ophthalmologist and we've worked through that and we're on the right regimens there. Now, how do we get to a place where I can read the newspaper, I can cook a meal? There's simple things that sometimes become very convoluted when we're struggling with low vision. Something that can seem as simple as you're looking in the oven to see if dinner's ready and you can't distinguish the color, right, of whatever's in the oven. Is it cooked enough? So do we have tools for that? Sure. So those are those kinds of things where, it's all good and well to talk about the medical, but now when you leave that office, how do you do things on your own? And that's what we are here for. So when we talk about low vision, there's a few categories I like to think in that help keep it straight. I think we have commonly heard you're the blind agency. And I don't want that misnomer to be out there that we will only help people who are blind, because it's simply not true. The best way to describe it is what we like to call visual impairment. And just like any other thing, we talked about diabetes, you could be borderline diabetic, or you could be diabetic for 10 years. Just like everything has a spectrum in medical, so does vision. And so I don't want people to think of us as the blind agency and only simply hear that they can come to us if they're not sighted at all, because that's not true. So we like to think in terms of a visual impairment and also progressive vision loss, because there are certain conditions, and we'll talk about some of these, where your vision would progressively naturally get worse with a certain diagnosis. And it is always good to check in with us as things start to be difficult so that we can follow your case, and it's easier to jump in and assist when something gets a little more troublesome. So again, I don't want us to jump to the picture of VIA is only there for people who are blind, because it's not true. So visual impairment simply means your vision is not functional for what you need to be doing, or whether that's need to be or want to be, really, for the joys in your life that you have. One of the things I know for me is important, and it's a little outdated perhaps in the world, but I love reading greeting cards. My uncle still sends me greeting cards, and if I lost that, that would be a huge loss to me. I value, as I said in the beginning, reading, and an audiobook doesn't hit the same to me. I will do that if I have to, but right now, I would value more any book lover will tell you the turn of the page, the smell of the book. So again, that's where we talk about visual impairments. To be legally blind is another category where there's certain criteria, and we won't get into that because it's really not necessary. But when you are legally blind, there's a variety of service we may be able to offer through our partnership with the New York State Commission for the Blind. So that's the really important distinction. But again, we know all that. We'll work with you on that. You don't have to remember that. This is all just for an understanding. There are different programs depending on your life stage and your goals. So one of the programs, if you are legally blind, becomes what we call ALP, and that's our assisted living program. And you would have to be legally blind for that. And that comes with other services. So sometimes people call and they say, well, I'm not legally blind, right? So we're past the I have to be blind part, but gee, I'm not legally blind. I advise people after a phone call to flush out what's going on. Even if you come in for a visit with Dr. Simmons, you will get that 45 minutes to an hour of FaceTime to discuss some options. And I think that's a big difference that doesn't happen in a lot of medical practices. So even if you're struggling with some sort of visual impairment, I encourage people to have that discussion, because what can happen is he may walk through and talk through some possible solutions pertinent to what your vision struggles are. So I also don't want people to hear, well, gee, I'm not legally blind, or I'm not this criteria, I can't have services. Because sometimes, I mean, and oftentimes we have people leave here and they're thrilled at the variety of things that they can do just based on a discussion. Sometimes they're minor adaptations, and sometimes we recommend equipment for you to purchase that will make your life easier. So I think that's the big difference. And I like to explain that because I could very much appreciate, as a patient, as a customer, if I go to a doctor's office and if I were at an ophthalmologist and they said, well, here's your vision, have a great day. I would leave there thinking, well, what do I do now? Like, you just told me I've lost some vision, and we're the and, right? So we're going to talk about functionally how to assist. So as I had mentioned, there are some primary things we see here. This list is not exclusive to all we do. These are just the common things we see. So if you're listening and seeing this and you have some of these, hopefully it just puts it on the radar, and you might not be at that point, but it also perhaps for loved ones, just knowing that there's a lot of coexisting things. So I had said, diabetic retinopathy. So in its very simplest form, people with diabetes do have a higher risk for some loss of vision. So you don't have to remember all the fancy medical terms. We just have to think about, I'll always talk about function and the down to earth things. So again, diabetes, usually we see a high proportion of people who have diabetes and are also, that is affecting the blood flow in the eye, thus decreasing their vision, and they come to us. This retinitis pigmentosa, and yes, that took me 2 years to figure out how to say. So again, don't worry about that. But pretty much, I think we all have an idea that the retina does some imaging, we'll call it. And it's really just a dysfunction to the retina, which is very important for an actual picture, if you will, when you see something. Glaucoma is something too, as that optic nerve transmits the messages. The more we put pressure on the optic nerve, obviously the less transmission, right? I liken this to, you run a hose in the summer and you put the kink in and the pressure is building and it doesn't come out. I think of that with glaucoma. Macular degeneration is also, I would say, diabetic retinopathy and macular degeneration are probably the two most common things we do see in our population. And I think one of the slides I have gives you a little sample of what that looks like. And cataracts, we see some, we don't see a ton of that. Same thing with injury or trauma. We don't see a lot, but that's not to say that we don't help with that. It's just, I'm wanting you to be able to relate to if there's something in your life. But these are all examples, not extensive examples, but some of the more common ones we will see and work with to help get that vision to a functional place. So again, that ophthalmologist or medical doctor will help you manage these. We're going to help with the function. So again, we talked about this a little bit in the beginning and talking about like low vision and what does that mean? And we had said that essentially it's just not enough vision to do the things that you want or need to do. It's, it's always, yes, what I need to do becomes first, but then what do I want to do that's going to give me a good quality of life? Because we don't want to ignore those things. Anything that is going to distort your joy is going to have some other effects. And when you can't do the things that bring you joy and give you purpose and meaning in your life, we're going to be then at risk for other things like depression. And so there's a snowball effect if we don't treat some of these things and work in the functional realm. So the biggest distinction I try and make when someone's not sure if they're in the right place is when we talk about a visual impairment, it's the uncorrected vision loss, right? So I'm sorry, uncorrectable, right? So if you can put on glasses or use devices and you can correct something, that's not what we're talking about here. We're saying you have the glasses, you're at max for what you can do. We're stuck. We need some help now. That's when we're talking about visual impairment. So like I said in the bullet below, you can't improve, you're at where you're at. And so that's when, again, we step into that when you're visually impaired. And it's the standard glasses aren't working. And that all of it's not working, that's what we're here for. Legally blind, these are again the technical difficulties, but I think everyone is familiar with what we call the Schnellen chart, the letters. The technical, measure of that is 20 over 200. Again, I don't really, I know Dr. Simmons has to look at that. However, I still stand by if it's not functional for you, right? That we do have some people who have better than this legally blind diagnosis of 20 over 200 and are still struggling, and that's okay. So I don't want people to think that it's a disqualifier. But again, there are more supportive services when you do have this diagnosis. So what we will often ask people on the phone is, are you aware if your diagnosis is legally blind? And that's only because it helps us route you to the right people. Being legally blind too is, I just want to make this distinction because essentially you really can't see, but that doesn't mean we don't have what we call light perception. So, being blind, again, that lies on a spectrum too, where it's not just you're blind. You might have light perception, you might not. As you can see in here, we're talking about, when we talk about visual fields, it's literally how much comes out of these sides as well. So there's a lot of categories, and you can see where, as we talked about in the beginning, the array of people who are there to support vision is necessary, because look at all these little nuances we're having to look at. And this is just an overview today. So this is one of the things when people come in with vision dysfunctions, this could be how something literally looks to somebody. So I do like this slide because I just think about, here, let's come back to functionality. And if I'm navigating and walking in my house and this is literally what I see, there's a risk, right? And the risk is when you're only getting that much of what we call your field, visual field. This is very narrow. And so I look at this slide and think, if my eyes only saw that, I could very well stub my toe, which would be unpleasant, but functional. However, I just see this and I cringe as an OT and go, that's a high fall risk. So I think the other thing to consider when we talk about where is the function and how much function do we need and what are the impacts, when I look at something like this and somebody who is seeing this kind of a situation, I go to, my gosh, there's an increased fall risk. So I don't think it's just, and statistically that is true. Statistically, we do know that people who suffer with some sort of visual impairment are at a higher risk of fall rate. And I think this slide is a great example of that. So I want people to see this presentation today and say, there's somebody who can help me, because I very much appreciate, again, there's a lot of frustration when you go to a medical provider and their job, and they're doing their job. Their job is to get you, walk you through the medical. And unfortunately, they ship you off and you're like, and now what? We're the now what? And I like this job for that reason, is we are doing something different than what I think you're going to get with or I know you're going to get with a general medical provider, because we're the vision rehab people, we're the functional people. So again, we talked about this, we covered the fact that, blindness is different than visual impairment, legally blind, but it's all, again, what's the functional level? One of the things we think about when we work with people who are blind is one of the big factors, believe it or not, that plays into that becomes how long have you been blind? So that's very different to experience blindness through somebody who was born blind, or that's their recollection, say in early, 3 to 4 years old became blind, versus somebody in a traumatic injury who fast is blind and has lived their whole life with vision. Those two things look different. And so in the second example, where perhaps somebody has lost their sight immediately, is we might look at something like a social work service, because that adjustment is very tough. You have essentially, you've only known one way of life. And so, you know, unfortunately, if you were in an accident at, 40, 50 years old, and you've had 40 to 50 years old, if your brain and your world has relied on visual cues and it's gone in a second, that's going to require a very different treatment approach or functional approach than it would for somebody who has adapted their whole life to make the world around them work for them. So that's really the point in talking through that. So again, the other thing we get questions about is, and I think we covered a lot of this, but it's also nice to see the face. That is really actually the Dr. Simmons. And as I said, Dr. Simmons is our low vision optometrist. He's a certified low vision. We have therapists, but I technically go by optometrist. Either way works. So he's, even though this looks probably a lot like what you're used to if you go for your basic eye exam, the difference is, again, so he's going to look at your vision, as you see in the slide, and see what you're seeing. But after this, the difference in our low vision exam, and you could see the word low vision, right? We're not saying optical, we're not saying acuity, words like that. We're talking low vision. The difference isn't what you see in the slide. The difference becomes the conversation after he does his basic assessment about, let's talk about, now that I know where your vision's at, what we can do and how we can adapt things. We talked a little bit in the beginning, and I had said, VIA doesn't just have the low vision clinic. I'm going to, hyper focus on that today, only because it's a resource in the community that if I had a nickel for every time someone's like, I wish I knew, I don't want people out there wandering alone. I think there's a lot of fear around vision. So I do hyper focus on the low vision clinic, because if you're not sure, it's a great first step. However, I do want to talk a little bit about the other things we do here. And this isn't really, the purpose of talking about these services is not to, bring in more clients and whatnot. I think the value in understanding these services becomes, for at least me, there's more hope. And I never knew prior to working here, even being in the medical field, that there was this much assistance available. So this isn't a VSL per se on the services, as much as I think there's a comfort in knowing that there are dedicated professions to these vision things, and there's professionals that are trained, there's access to the professionals, and that it doesn't just even live in just our low vision clinic. I think knowing that you have those resources, that the community has that much support, in the very least takes the anxiety, the fear, it gives you hope, right? When you know that there are people who went to school for such training. At least that's how I look at this. So we'll go over that for that purpose. So one of the first categories of vision professionals, as I like to call them, is our vision rehab therapists, and you'll hear it commonly referred to in the community as VRT. I like to think of them as the vision rehab people in a very overly simplistic view. They are the therapy or rehab for the eyes. So as an OT, I look at that and say VRTs are the closest to an OT, but are hyper focused on vision. So they're going to work on things like what we call activities of daily living, like cooking. That's the VRT realm. They are specially trained professionals who know how to adapt. And I'll show you on the next slide exactly an example of that. But they're very apt to adapt you to whether it's high tech or low tech. And I'll give you an example. A lot of our vision rehab therapists, as they're working in our ALP program, they will do something as simple as place a tactile thing. So on a washing machine, when you turn the knob on a traditional one and you go to the settings, right now, if you think about your washing machine, right, you turn it and it's all visual. So you can turn, you don't know. And if your vision's not great, just a quarter inch of a turn could change the setting from hot to cold to gentle to heavy load. And so one of the common really low tech adaptations is our VRTs or vision rehab therapists will go into the home and place either a bump dot, which is literally like it sounds, it's just a raised tactile thing. We also put puff paint, let that dry a little bit. It's a very low tech, low cost thing, but essentially you're taking the tactile to help compensate for the vision. So laundry is one of those things everyone's like, I know how to sort my clothes and how to put it away. But I think we often forget about like, I got to turn the dial and find the right setting. So vision rehab therapists, that's one of their common tactics, and it's one of the common things they see. Same thing with cooking, cutting, eating, that visual contrast becomes tricky. That's the stuff that they look at and work on. One of the more mysterious professions when it comes to vision becomes what we call orientation and mobility instructors. You'll hear that in the community commonly, they'll call them O&Ms, and that just stands for the orientation mobility. The easiest way to describe to people orientation mobility is that essentially when you see someone who is fully blind using a cane, they're the people teaching how to use the cane. And it's a very overly simplified view of what they do, but I think it's the most relatable. But it is like it sounds. So it's orienting to your surroundings, mobilizing or navigating. They teach those things. I have some O&Ms right now that are working with children, and they're teaching them how to listen for traffic, and we compensate with auditory there. And they're orienting to their environment based on auditory. That's what your orientation mobility specialists do. The more common service in that ELP program I talked about is vision rehab therapy, the previous one, but we do have some times where orientation and mobility instructors or O&Ms are in the home as well doing service. And one of the other services, believe it or not, that is with this, and this was a little mind-blowing for me when I first came here, was social workers are key. And I think the greatest, most straightforward example is somebody who quickly loses their vision loss. And coping with that, that's an adjustment. And so social work, that's one of the most clear-cut reasons that we would have social work. However, just like any other avenue of social work, it does become linking to community resources. One of the big pieces that our social workers do is advocacy. So how do you advocate for yourself when you're out and about and things aren't adapted for you? How do we navigate that? So I do just want to distinguish that because we do get some, not a ton, but some calls that people just want social work, and it's not your typical outpatient counseling, not like that. It is strictly related to vision. But again, I thought it was really interesting when I had started here that there is a whole sector of something like social work that is carved specifically out for vision. So again, if you are struggling or you know someone is struggling, the reality is there's a lot of ability of support around that. And these professions exist. And I think just again, knowing that there's merely an existence of support is a very big comfort. If you're either starting or currently struggling with vision, it takes some of that overwhelm out of nobody understands. Like, well, you know what? There are people who understand. There's actually people who went to school for this. And to me, that's a huge comfort. So we were just talking about vision rehab therapists. And so this is a very easy example of, again, I told you in the beginning, I wanted you to leave here today with something you could take with you as you go. So this slide and the next slide are my, here's something you could take with you, use it if you want. If you don't, I'll never be the wiser. So one of the very simple things when we're talking about low vision is contrast. And I know most households, I know mine, oh, that's not true. I take that back. Most households have white plates. This picture shows you how nice it would be to have, or the contrast, not how nice it'd be, the contrast if you use a dark plate. So I kind of lied to you guys. My plates are purple at home. I forgot. But so I always think about if you look at the dark plate I have on your screen. So right now it is a dark circular plate. If you put a scoop of mashed potatoes on there, that is an easy find. But if you put that same scoop of mashed potatoes on a white plate and you're struggling with your vision, that is harder. So sometimes it's not even about, you know, people call and want to buy something or do something high tech. And I'm like, change the color of some of your plates. You can see on the right upper hand corner, we have a mug and that is white. Now, I have mugs at home again that are dark inside. Imagine, again, simple task, pouring yourself coffee in the morning and the inside is dark. And that contrast between the color of coffee and a mug that interiorly is a dark color like black or green or blue, that's hard. But you put your coffee in a white mug and that contrast between the colors, it's a simple, quick fix. What I don't have pictured here is there's also something, our people who are totally blind often use this. and it's a liquid level warning. So you put it on the side of the cup, and as the cup is filling, it will beep when it gets close to the top so you don't over pour. So that's the mid tech, right? So it's not low tech where you can just go buy it, but it's also something really simple. You just put on the side of the cup and it's going to beep for the auditory to tell you. You'll see on the upper left corner, we put a bowl where that interior is white. So when I look at that, I think again, if I put my salad, the green and white is a nice contrast. So if I'm struggling with vision loss, that's a nice contrast. So very low tech things. Also, this seems simple, but if you notice, there's a placemat. And what that placemat is going to do, again, these are super simple things, but you'd be amazed at how much they can help. That gives you a visual boundary, right, of where your place settings are. You know, in front of you, you have a square of whatever dimensions. You also unknowingly have, even if as you pick things up, you're going to tactilely with your fingers be feeling, am I on the placemat or am I on my table? That's a piece of orientation that you're probably not even cognizantly processing, but you know that all of your food and meal not has to, but is staying on that placemat. So that's one of those sneaky ways of getting some orientation in, that all of the things I need for this meal are on this rectangle. And again, you can notice the contrast there. So that's a very simple setup that if you walked into, and I love talking about this setup because there's a stigma when we adapt things to technology, and I don't want anyone to ever feel stigmatized or like I don't want anyone to not fit in. And when you look at this, this is extremely normal setup. If I went to someone's house or you went to someone's house and you saw this, you'd have no idea that this was even adapted for vision, right? This just looks like someone's servingware and it looks like a setup. It doesn't have any, that level indicator talked about doesn't have that. So I love this for the functional aspect of this is a way that you can be adapting things at home without expense or high expense. And also it's very normalizing. If you went to a restaurant, right, you can apply some of these tactics. I'm sure if you asked, they had a placemat, and I'm sure that even if there's not the color, where you want, could you ask for something in a bowl instead of a plate? Because, the plate doesn't have a great boundary, right? It's flat. Perhaps a bowl, asking for them to put something in a bowl. There's really simplistic ways to adapt. And that's where, even if you don't qualify based on your diagnosis or vision loss, those are tips we can go over with you when you come in for a visit. Some of the other tips that you can walk away with today is black and whites. You're obviously your highest contrast. One of the fascinating things I find is to avoid glossy finishes. Now, I am not suggesting that you go home and change your wall colors today or immediately run to a home store and change everything to matte finish or satin finish. But it's something to be cognizant of. I think, as you put up reflective things or things that can be glossy, I've noticed it now that I'm working here, reading in certain sunlight. It's actually too bright for me when the gloss hits it. Another very simple low tech thing is just as you buy a cutting board, I shouldn't say most, but what I've seen mass production is white cutting boards. And that works if you have white cutting a carrot, right? Orange and white, that's a great contrast. But you cut up something like you're peeling or cutting potatoes, now you're talking white on white. So even something as simple as getting a different color cutting board. And I know personally, I have the cutting boards that are thin in different colors. I'm sure I could double that as a placemat. So that would give you more boundaries. So there are some low tech things we can be doing. Pots and pans, the interior of that for when you're cooking. I know a lot of them with the nonstick are dark, but I've also seen a lot that have a white background, and you know what you eat and cook regularly and you can adapt it for that. Solid color bowls are better. Again, mine have a pattern, but if you're looking to make a quick adaptation or something that looks normalized, those are some quick tips. One of the other things, and I hear this the most from visits, is it's interesting to me how helpful in changing this is, and it's lighting. I actually had one of my friends come in for a visit and they were struggling with reading and they had the right prescription, glasses were fine. And this is funny, it was such a simple switch. So in the picture I've shown you on the side, that's what it is called the 5 lamp. And what the suggestion was, believe it or not, the way that is set up, that is actually how my friend was using this, or a light, let's not say this light. So after a visit with Dr. Simmons, the suggestion was merely this, was that you could see it's a gooseneck lamp. The suggestion was bring that closer to the page of the book you're reading, because when it's up high, like it is in this picture, and it's casting shadows, and your shadow of where your body is making that harder. So by bringing it down and you put the light onto the page itself, you're casting the light onto the thing you're trying to read. That is I didn't even think of that, right? And I've been an OT for years. So something as simple as we just changed where we're putting the light and then she's reading totally fine now. So this is one of the products, again, we get no kickback for this. This is just something our patients have told us has been very helpful. That's called the 5-lamp PHIVE. And what the reason people like this is, again, that gooseneck where you can angle that. It also has, I think it's 3 different light settings where it's low light, medium light, bright light. So you can change that. You might think bright is always better, but sometimes there's too much glare. And so you need a lower level of light. And in the previous slide, when we talk about lighting, we did talk about the glossy finish. There's also that reflection from mirrors. There's certain times a day I know that the sun comes in and hits a mirror or that glossy surface, and that light is like not helping. It's too much. So the contrast is we need adequate lighting when we are in places. I think stairwells are really tricky because sometimes you don't have lighting there, right? If you don't have in-ceiling lighting, there's no lamp. So I like the idea of the 5-lamp because I'm sure there would be a way if you had a stairwell that wasn't well lit to angle that in and out of your way so it's not a tripping hazard because it's that bendy and you can place it in different areas. Some other just things are, and again, we take these for granted, but here's the reality is if you keep things organized into the same place they should live and their regular places, you don't have to rely on your vision. And so if it's tough. Everyone has a junk drawer, but once you start to have a functional vision loss, how do you find the super glue in a huge junk drawer? That's tough. So sometimes that elimination of clutter and just staying organized is really helpful because you are reducing how much you have to rely on the vision that is left and you're lightening that load on yourself. Using larger print items. There's, I know, again, the reader and me, there are large print books available at the library. Sometimes making that modification when I send things with our patients, I do try and blow up the font. It's a simple modification, but sometimes that's really helpful. And to that point is we get a common call again that talks about, I want to buy a magnifier. And unfortunately, we have the displeasure of saying there's no such thing as just a magnifier here. So perhaps at Barnes & Noble, you can get a magnifier, but here our magnifiers are prescription strength. And there's a reason for that, right? And that's part of that low vision visit with Dr. Simmons is we can go anywhere from we call a 3x all the way up to 10x. So that's a huge, huge gap, right? 3 to 10 is a lot of different magnification. And in case that's not confusing enough, is you can also get a magnifier like you see in the picture in the middle of the slide. That is a handheld that goes right over it and has a light. We have other magnifiers that are on a stand, and there's other magnifiers with yellow light versus, so there's, besides the strength, there's a lot of different magnifiers. And it would be just way too unreasonable to expect people to figure that out for themselves. So that's one of the biggest things we use and recommend. I will be honest that insurance really doesn't cover these. So I don't want to be misleading to people that you can just go get these and your insurance is going to pay for them. I will be honest about that because I don't want to give false hope on that. But magnification is huge because there's certain things, like one of the biggest things that always sticks out to me is expiration dates on food, right? That's a safety issue. Especially you're talking things like dairy. So having the right magnifier or some kind of magnifying device can really be a safety thing at that point as well. Reading price tags. So here's where we got to talk about the function again. A lot of people will call for what you see in the very lower part of that slide, which is what we call a CCTV. Well, you're not taking that grocery shopping if we're just going to be honest, right? So let's talk about the functionality. Now there's people who want them. Let's say you're doing something from home or you're working from home and you need that. That makes sense. But we also have to think about if you're going to a restaurant looking at a menu. So these are all things we can work through for what we do here at VIA. To the other side of that, there's all sorts of stuff out on the market right now. We use what's called LS&S. That's one of the distributors, Maxi Aids. you can find anything on the internet now, or you can call these places directly, but there's a lot of things when you can't see well, what we adapt most is talking and auditory. So that scale that I have on this slide, the scale reads your weight out to you, which honestly sounds awful to me. No, just kidding. But it will read it out loud because, especially I'm really tall. I'm 5'10". So I can't imagine, standing that high off the ground and peering down if you're visually impaired to see that number. So it'll read it out. Large button phones, talking watches, again, that's that auditory compensation for when your vision isn't working for you. And it does become a safety thing. So there's, talking thermometers. So we know how hot something getting so we can avoid burns. Something, here we go, very low tech simple is a very long sleeved oven mitt, right? What you don't realize is when you go into the oven or whatnot, that a standard oven mitt comes to your wrist. If we have longer sleeves, it's okay if you misjudge the length of you going to the oven because you're covered and protected on that forearm now. Very simple, but very functional. And the reader in me always likes to promote the library, not just because I love reading, but they're also, in all seriousness, a very great resource. And I do apologize for the print. I played around with this. I cannot get it bigger. So I will read through some of this. And, we talked about in the beginning, there's audiobooks. Fortunately, the library is pretty inclusive where there's physically CDs. There are also electronic, ebooks that will read auditory. So you have a variety if you have a preference. There's a lot of great stuff. We've actually worked a lot with the libraries around here and given them some of our materials. We do get questions from them. So because it's not just a library for books, so think about this, the library is a spot where you can use a computer. So if you have low vision, those are going to be some needs as well. So because the library is beyond books and it is a community resource for things like, tax season, right? I do bring that up because I like to plug it as a resource because it's a free, low cost resource or no cost resource. But additionally, to give you the confidence that we actually do work with our local libraries here and that they're aware of our services, the technology, and they're sensitive to that as well. So, again, the biggest default is tax season, the free tax forms, or the use of their computers that goes beyond books. So I just want some comfort to be there as a resource for you as well. I always leave some time at the end because, again, I know this is a lot of content. I hope that makes sense, but I am absolutely open and left some time purposely for anybody who has questions. I am open to that.
Okay, thank you, Amanda. Great presentation.
Thank you.
We do have a few questions in our chat box, and if anyone would like to add them now, feel free to do so. Or I can unmute you. If you use, there's a little icon. It looks like a hand like this at the bottom portion of your screen. If you click on that, I can unmute you and you can ask a question verbally. But let's go to the chat box first. So our first question, Amanda, in the chat box is from Jim, and he asks, what can we expect after laser I can't say the word, it's TRABECULOELASTY.
Okay, I'm not familiar with that procedure, but I'm going to take the easy way out on this one.
Plasty.
So the suffix is plasty?
Yeah.
Yeah, I'm just going with my medical terminology there. That is usually fixing something, right? Plasty, like rhinoplasty is fixing a nose. So I don't know what to expect, but Jim, this is the really good news, right? So your eye doctor, eye surgeon, whoever that is doing the medical care, taking care of that particular situation and doing that surgery, they can get you. We talked about corrected vision. My hope and my assumption, and I'm unfortunately not familiar with that particular thing, is that that will get your vision to the best place physically and medically we can be at. So as far as what to expect, it's just like anything else. Unfortunately, some people, when they wake up from anesthesia, wake up better than others. So the good news is that, you have someone medically addressing that and you found that right place. So the next thing is, I don't know what to expect after that. However, right, this is where if that medical intervention doesn't meet your needs or expectation, there's a backup plan. And that backup plan is whatever functional vision things you would like to have addressed. That's where we as a non-medical intervention can assist there.
Okay. And then the next question is also from Jim. Same person. He asks, what can you tell me about open angle glaucoma treatments and eye pressure?
So
Open angle glaucoma.
yeah, so the glaucoma stuff and the treatment, so that goes back to that medical realm. So the actual treatment piece that lies in the ophthalmologist, and that's going to be that medical intervention for you. And that, unfortunately, this is the thing with the spectrum of vision, right? Is that everyone is different. There's people who we've had in here who have glaucoma, no two glaucoma cases have been the same. I'll be honest with you on that one. So as far as expectations, that's really got to be a conversation because there's such a wide spectrum of results there. That's between you and the ophthalmologist, which again, it sounds like you're networked really well, which is excellent. And then once that your medical interventionists that are treating those conditions and it'll get you to your best medical intervened vision, whatever happens after that, if you ever need help functionally after that medical intervention, there's something residual that you're not happy with, we can work with you on compensating or adapting. So it sounds like you're in the right places for knowing these procedures, but the outcomes as far as that do lie in that medical community you're connected with.
Okay, and another question here is pretty simple. Where are you located?
Oh, thank you. I love when I get questions that I don't think of because then I plug them in. That's a great question. So our clinic is down on Main Street in Buffalo, 1170 Main Street. And that is this is funny. This always hits. I tell people we're diagonal from Anchor Bar for some reason. Ironically, pun intended, Anchor Bar is the anchor for where people can recognize us, but not far from the Buffalo Niagara Medical Campus either. We're very close to that. So we are located in the city.
Okay. All right, did anyone else want to ask a verbal question? I see Jim has his hand up. Hang on, Jim, I'll be right there. Okay, well, hang on.
Okay.
Okay, Jim, you should be ready to go.
There's actually two people here, me and my wife. My wife's the one that's having the surgery,
Okay.
but I'm blind in my right eye and I'm a diabetic.
Okay.
Do you have preventative maintenance, things that we could work on? Because eventually, my mom went blind. She wasn't blind in one eye, but she was diabetic also. So, you know, you kind of want to preserve your sight as much as you can. And doctors are just going to give you glasses and stuff. So I just wondered if there was some sort of preventative maintenance that you use or is available.
Yeah, so I'll preface that with, and it's so funny, I feel like unfortunately, an attorney here, I don't get paid when an attorney gets paid. However, I'm not a medical doctor, so I always throw that out there first, and I'm not giving you OT advice. As far as preventive maintenance advice goes, that unfortunately does fall back to the medical realm as far as like, is there medication? Are they going to prescribe? And I'm making this up. I don't even know if this is pertinent to your case, but eye exercises to be using those muscles of the eye. That's something that the medical provider would know and would have to advise you on. However, as far as preventative maintenance, so let's drill that back a little bit. And you had mentioned diabetes. I heard you say that. And it's weird. It's not a direct answer, but it's unfortunately the truth is that the better you can manage something that's causing it. So let's say the diabetes, the better the diabetes is managed, that should hopefully, if the eye condition is secondary to the diabetes, right? And we're feeding the blood vessels and the sugar levels, because the sugar levels are what really interfere, from my understanding, with the blood supply. That's the bigger issue. So I always say to people, like, working on your baseline medical stuff, because it's all of the baseline medical, right? So the diabetes and all that, I look at it as a feeder to the eyes. And um, yeah, so I always recommend to people, the more you can do for those baseline medical things and keep them managed. Having worked here, I'm hyper vigilant to diagnoses of diabetes myself, because I do see that. So for myself personally, I can tell you that I get my labs drawn every year, and I keep an eye on, I read my own labs. So managing the underlying condition. So that's tricky, because who's managing the diabetes? And if it's your general practitioner, they might do that. It might be a nutritionist. I know there's a lot of healthcare plans who are now paying for nutrition, but as far as like preventative, it's best to manage the underlying conditions and your general health, because that blood supply, even diabetes aside, is crucial to the function of the eye. So managing your overall health feeds into that health of the eye. But as far as, preventative exercises and like using those muscles and using your vision, there's not really much that we hear prescribed, because that does fall back to an ophthalmologist for the medical care side of it.
Okay.
Kitty, you're muted.
I go back and forth. I forget sometimes.
No problem, yeah.
Does anyone else have any questions? Either verbally, I can unmute, or in the chat box. We have Sandy, who thanks you for a great presentation
My
and
pleasure.
great tips on color contrast and reducing glare.
See, I told you you're going to leave here and get something out of it.
And we have Susie. She says to everyone, I volunteer with a nonprofit organization, and we're making every effort to increase accessibility
Great.
to our website and social media.
Yes.
You know of it? Do you know of any tools for alt text, ALT text?
So we do a lot in-house, and it
Alternative.
just makes me happy that that's being talked about. So thank you to the person who wrote that in, because that is something that's commonly overlooked. I think, especially in a world of social media, we are constantly, right? We put emojis and things. So, that alt text, so just to clue everyone in there, is a lot of times when you put a graphic in something, that alt text becomes, usually it's underneath it, I'd say most commonly, is it explains what the image is, right? So if I had this is why you'll notice as I'm explaining things, when I was doing the slide on the setup, the plate and cup, if you notice, I was very particular how I said the cup in the upper right, right? So in case we had any visually impaired people on this call, they would be able to somehow get to the orientation of what I'm saying. Alt text is like that. So if she had a picture of that setup, the alt text below would be like, picture of black plate in middle on top of blue placemat with utensils to set. It really just describes the image, so that somebody who is visually impaired or blind can appreciate and be immersed and enjoy that same experience. As far as accessibility, it's not one, I'm giving everyone like the non-answers, which I hate doing. It's not one method, it's not one program. It is really just trial and error and testing. So here we worked a lot on our website, and what we ended up doing, my best tip I can tell you, and it sounds a little common sense, but unfortunately we don't do it often, or the general community doesn't. If you can get somebody who really is visually impaired, and I'll be honest, I just did that before I hopped on this call. I have a position open I'm hiring for, and I'm looking into hiring somebody who's visually impaired. And I called down one of our staff and said, can you help me make sure it works? So it wasn't just, I didn't just read like, oh, this app or this website, right, is good for this. I immerse and test it with somebody who is truly visually impaired. And that, even from the OT perspective of sensory, we often don't talk about it, but we don't participate in it. So my biggest tip is, if you can find somebody who actually is blind or visually impaired, and have them test it first. So we work with our board. I'll tell you this too. We work with our board, and a lot of they're notable community partners. You would know, they're people in our community. Kitty had mentioned a couple actually earlier, and those people, what they had found too is just the awareness. So you're asking that question, just the awareness of it being accessible is huge. And because the one corporation was aware, they looked into it more and worked with some IT expert, and they found out they were not as accessible as they thought. So even just having that awareness and asking the questions, there is no, unfortunately, there's, as far as I know, there's no magical, like, it'd be nice if there was a site or system that scanned for accessibility. But what we've really found is we just ask people who we know who are visually impaired or blind to surf our, web page. And that's where we found out. Or, right, so here, let's take it even lower tech with alt text. We did an overhaul and we reduced the visual clutter on our page, right? So for people with low vision, there was so much text in there. It was like reading a book. I was like, I'm a reader, but man, I'm done with this. And the visual clutter was brutal. So at a very basic level, right? If we can do visual clutter reduction and we're cognizant of the accessibility, that's a huge step. The only other thing I have come across here that's been a real life lesson to me, and it doesn't go to just websites, it's more what I was made aware of is if you're working in like Word, for example, Microsoft Word, that the text is accessible, tables are accessible. However, if you copy and paste a graphic, something like what we call JAWS, which is Job Accessibility with Speech, that's an adapted program that reads a screen out to somebody who is blind. Those images do not read. If you're talking about people who use things like in their daily life to find your website per se, to use what we call as JAWS, the images are very rarely accessible, and that's why alt text is so important, because that descriptor text will read. So the other common thing I had found out with Adobe, same problem. Adobe is very image based, and you can get some text fields, but anything like you put a graphic, or I put a digital signature as an example. When I use Adobe at work, my digital signature, that doesn't read. So, if you can be cognizant of the readability, literally words, letters, like those kinds of things actually read. Images are tough, and that's where alt text comes in. So those are some very surface level pro things, or surface level things that you could be vetting in the meantime, just to be cognizant of the accessibility. And the last comment I want to make, and I'm sorry, it was a great question, and it actually leads to something else, is that, we talk about accessibility, and I think the world has gotten a lot better with being, there's a concept called universal accessibility, right? And that, or universal adaptations. And the concept there is that when you do something for one person, it's easier for everybody. And so I think of curbs, you reduce a curb, or it's like you have less of a trip hazard for everybody, not just somebody who can't manage it. And so to this point, the more you make things accessible, even in this realm, is that it's not just acceptable to, or accessible for the blind population, but as people are aging and their vision becomes worse, you're going to be ahead of the curve. So I really applaud that cognizance and the effort. Thank you.
Okay, and then we have one more comment in the chat from Cassidy. She says, nice presentation. The visuals with the contrast, especially helpful.
Thank you. I love the feedback, I love that. It helps.
Okay.
Then you help me help other people.
And Jim, did you have another question? I see your hand up there. Oh, okay. Let's see. Nope, he does not. So, okay. Well, I thought that was wonderful. Amanda, thank you so much for your time today.
Thank you for having me.
If we had many attendees, so, possibly we'll have you back in the spring.
Great.
And we can go forward. All of it's very important. And so we'll follow up with you on that.
Fantastic.
And thank you everyone for attending.
Thank
Have
you.
a great day.